let me throw a little something out here on the pay for performance still. Ken mentioned earlier, he explained to us entirely what Safeway was doing. Is this the kind of sea change that has to happen for pay for performance to really be a success?
Yeah, I think so. I would say that there's an opportunity for us to end up with a piecemeal approach or system as a result of what's playing out. And ultimately what we want is reform, which I don't think is going to happen. I think this is more about insurance reform. Delivery system reform really has to get to the heart of what Ken is saying, and that is, if you think about care from the perspective of prior to my ever being diagnosed, I have a predisposition to illness. Our ability to, one, understand you and understand your behavior, and then to look at care going from predisposition to chronic condition to death. I mean, that shifts us to not paying for episodes along the continuum, which is what the current system does, to really shifting and looking at population. And so until we really are incented to care for the whole of the person or the population, I mean, I don't think we're going to see significant changes in the delivery system.
One last on this issue, because it's a very important issue. You said that Dr. Emanuel was listening quite closely. Noting that you've indicated we're seeing insurance reform at this point more so than delivery reform, do you think there's a part two coming down on this whole reform process, any of you?
Yes, I think the minute the bill is signed, assuming that it is signed, that Catherine Sebelius, Secretary Sebelius, is going to become the most important person in the country. And the reason is that the attention of public policy will shift to delivery system change, because it's the only way to get at the cost curve. And what we struggle with is trying to understand why it's taken so long. If you assume that this discussion started with Teddy Roosevelt, it's been so difficult to get at changing the system so it provides better care. And from our perspective, the issue really is what Ken brought up earlier. We have a 19th century model and a 19th century psychology and a 19th century set of values around health care, which prohibits us or has inhibited us from getting to imagine what would be a new norm. And a new norm is a less fragmented system, and it's based on up-to-date science and delivery of care through teams. And the incentive system, which we've been talking about, is going to, at some point, get us to the place where, for all of my angst, we look like Kaiser, because that is, you want your physicians linked up with your hospitals, plugged into your finance system, reporting back to you how good a job they're doing. And that's the model we have to get into. It's away from an individual model of a doc, Marcus Willoughby with a black bag. Instead of the black bag, it's a laptop computer with a camera. On half your screen, there's 3 people talking to you about your health, your medical care. On the other half of the screen is your medical record. And we've got to move into a new paradigm to get at the cost issue.
I would posit also that you would include patients as in that partnership. And
they're looking at the screen.
Absolutely. There you go. All right, let's go to that cost curve issue. What has to be in the final version of whatever bill is brought to the president to bring costs down? Oh, don't all jump at once.
Oh, I mean, I think there are a lot of things that has to be in the bill. I think Ken touched upon it. The professor touched upon it. I mean, what's that thing about what's the definition of insanity? Doing the same thing over and over and expecting a different outcome. I mean, most of us have we've seen this coming for almost 50 years, that we were going to get here in this crisis. I remember sitting in national meetings and people were talking about, we've got 7 million people in this country that are uninsured. My God, what will happen if it hits 10? We're now approaching 50. And those of you that, like myself, that are, fascinated with history, you would note that most major change in this country, historically, you pick the discipline, have all happened at a crisis time. And ladies and gentlemen, we are, at a crisis. So yes, I think that we can bend the cost curve. I mean, we're one of, like Kaiser and others in this room, we're one of the major providers in this country. I've said this on Capitol Hill. My costs are too high. But we've got to, we can't be tinkering around the edges, which some people talk about. We've got to fundamentally change the system. The system was built upon rewarding episodic or more gadgets coming out of the healthcare system. That's what it was built upon. That's what I get paid on. That's what everybody used to get paid on. We've got to change that cost curve, and I think that we can do that. And I think that the insurance companies recognize that there are some things that they can do differently. I think that providers understand that we're going to have to. We cannot. This country cannot sustain our rates of increase. I think the utilization of technology, we're one of the few industries that over the last 60 years, how we process or do our backroom operations virtually have not changed. And I think the things that Ken talked about in terms of what I'll call the broader employer environment can make a difference, and we can drive down the costs.
All right, so we've got an overview and two clear-cut points out of this: technology and behavioral incentives. Gentlemen, is there another one or two key points that would have to be included in this bill?
Well, you're going to have to phase out fee-for-service financing for healthcare services, and that's what Lloyd is talking about.
Right.
You have to step away from that, and you have to phase in paying for quality, pay for performance. There's a thing in both bills, in the Senate and the House, that both seek to create accountable care organizations. An accountable care organization is an entity which can bundle payments for patients and base it on outcomes. So you put it all together. So ACOs have to be promoted, fee-for-service has to be phased out, and payment for quality has to be phased in.
Question on that, if I may, just to follow up very briefly. If you recall, we heard a discussion about how HMOs have been drifting toward PPOs, and I would suggest that that might also be in part due to market choice and what people got in return for what they spent, and it may have been different than what they expected. Certainly, you can phase out fee-for-service, but if you don't deliver what they need or what they expect or what they're paying for, how will that work?
I think that's an important point, and I think something we've got to do in terms of educating the public, and I'm always struck when people talk about choice, and often they look at a large integrated delivery system and have a sense that there is a lack of choice. And yet, if you step back, and we've talked a little bit about, someone said that, going forward, we've got to have a modernized IT kind of connected system that is able to really vet and understand quality, look at individuals, look at service. And so there is this perception that we have as a people that the the individual doctor, that Marcus Welby is delivering on quality, or the fact that we're able to choose among those people or individuals or professionals, that we're getting choice. We've got to shift this going forward to kind of objective measures of outcome. And I think, when we talk about shifting from fee-for-service, we really are talking about creating what is an accountable care organization, what is an integrated delivery system, but organizations that are incented, again, to provide care across the continuum, not based upon, reimbursement, but based upon outcome, based upon the intervention that's going to change behavior. Failing to do that, we may get short-term improvements in cost, but if you think of health insurance premiums are really the cost of care provided divided by the population. So unless we do something about the care that's provided and know that it's the right outcome, it's the right incentive, we're not going to have a lasting impact on cost.